Welcome back to From Fear to Fun, the podcast where we explore how to transform medical encounters with children from moments of fear into opportunities for fun, with connection, confidence, and cooperation. I'm so glad that you are here. Today we talk about a difficult but essential topic: misguided parental expectations. Because some parents come to the consultation with a dream of perfect childhood, perfect health, and perfect protection. And when reality intrudes, the emotional fallout can be intense. Let's unpack why this happens, how it affects the consultation, and how we can guide families back to solid ground. Let's start with the brutal truth. The world is a hostile place. Children get sick, they suffer, they struggle. Upper respiratory tract infections, up to 7 times per year, are normal. Ear infections happen. Pain happens. Distress happens. But for some parents, this is unthinkable. They imagine an ideal childhood where the child does not experience any illnesses, they're never in discomfort, they don't experience setbacks, and they are never suffering. And when then illness strikes, the parents want to fix it right away. If it can't be fixed, someone must be at fault. Unfortunately, this is the parental la-la land. Understandable, human, but unrealistic. When a child suffers, the parents suffer too. Every normal parent would give a hand or foot to spare their child's pain. So when illness in the child happens, the parent feels helpless, frightened, overwhelmed, and out of control. And this lack of control is especially hard for fathers. In neonatal units, I've seen it countless times. Mother close to tears, father close to fight. Parents might come with misguided expectations because they cannot bear the reality of their child's vulnerability. How misguided expectations show up. Parents who feel powerless often react by keeping the pressure up. They may demand certainty, request predictions, ask for repeated or unnecessary investigations, question every medical decision, and challenge every explanation. They might seek second opinions to avoid facing reality. They interpret our uncertainty as incompetence, and their advocacy becomes relentless. The room is filled with tension, and these are the parents clinicians often label as difficult. But beneath the behavior lies fear. Parents may request additional investigations to regain a sense of control. But unfortunately, with more tests come more time spent in the hospital, more resources utilized, often more invasiveness. Unfortunately, more tests lead frequently to more uncertainty, because every result comes with a margin of error. And last not least, there is an increased risk of false positive results, so where the test claims that something is found, although there's nothing behind it. Every test must be guided by clear questions. What am I trying to answer? What will I do with a positive result? What will I do with a negative result? And will this change the treatment plan? Without these answers, we risk chasing result ghosts, abnormalities that are statistically inevitable but clinically irrelevant. As a clinician, we need to pause for a moment and ask ourselves what the parents really want. Because behind every demand lies a deeper longing, a longing for certainty, control, reassurance. Often enough, there's also a longing for relief from guilt. So it's not my fault that my child is sick. Or protection of the parents from making the assumed wrong decision. Some parents freeze in indecisiveness. Others push aggressively. Worst of all, a few may even threaten legal action. But the core need is the same. Help me feel safe. This parental attitude can catch us off guard. Especially young doctors are vulnerable to this. And then we risk to answer defensively. So how should we respond to this? Before responding to the parents, I typically ask myself and my students, whom are we treating? The child's disease, the parent's anxiety, the GP's uncertainty, the junior doctor's inexperience? Because once we know the true target of the question, we can respond appropriately. And strategies that might help is to explain to the parent what is normal. What is the range of normal findings? What is a normal variation? What is a normal disease progression? What are normal healing times? And what is, in ENT, a normal persistence of cervical lymph nodes? We need to be honest about uncertainty, because medicine cannot offer 100% certainty, and pretending otherwise erodes trust. In this part of the communication, we need to clarify shared goals. So, for example, we may say, we both want your child to be safe and healthy. Often it helps to name the fears. Like, for example, it sounds like you're worried that this will get worse. Or, it seems like you fear missing something important. On the other hand, we need to set boundaries around testing. With sentence, for example, like, this test won't give us the clarity you are hoping for. In essence, we need to bring the conversation back to reality, because wishes and illusion cannot guide medical care. When does it go too far? In rare and extreme cases, misguided expectation masks something more serious. Münchhausen by proxy. Here the parent, not the child, needs urgent help. This requires immediate safeguarding action and might be difficult to identify and to diagnose. In a nutshell, parents may come with misguided expectations. They believe suffering should not be part of their child's experience. But illness is unfortunately part of life, and uncertainty is part of medicine. And our role is to guide parents gently back to reality with clarity, compassion, and firm boundaries. When we address their fears, acknowledge their pain, and offer orientation, the consultation becomes safer, calmer, and more collaborative. And this is how we move from fear to fun. Thank you for listening to From Fear to Fun. For the moment, this is the last episode in the whole series, but I might come up with further episodes as questions arise. Until then, remain curious, offer connection, and keep moving from fear to fun.